Echocardiography reporting. You will learn how to write echocardiography reports for various cardiac pathologies. This will mainly include the findings and the conclusion. We will start with a normal echocardiogram. The clinical indication is a routine checkup. These are the findings for this example. You can start writing with the left ventricular function and dimensions. The first parameter is left ventricle ejection fraction, EF. Here it is 60%, that is normal. In the brackets, the normal values are written. It is between 52 and 72% for men and 54 to 74% for women. Keep in mind that these normal values within the brackets can vary amongst different institutions. These are not fixed values and are just examples. After that, we have the left ventricle internal diameter at diastole, that is 5.2 centimeters. It is within normal range. The third parameter is left ventricle internal diameter at systole, that is 3.4 centimeters. Then you can write about left ventricle wall thickness, which includes the interventricular septum and the posterior wall. It is 0.9 centimeters, so it is within normal range. Global LV systolic function is normal. No regional wall motion abnormalities noted. After that, you can write about the left atrial size. The left atrial diameter is 3.6 centimeters and normally it is less than 4 centimeters. Then we move towards the right heart. This includes the right ventricular and right atrial size and function. In this report, the right ventricular size is normal. The right ventricular function is also normal, and the right atrial size is normal as well. After that, you can write the findings of the valves. The first one is the mitral valve. Normal morphology, no mitral regurgitation or stenosis. Next is the aortic valve, tri-leaflet with normal mobility, no aortic stenosis or regurgitation. Next we have the tricuspid valve. It is normal, no tricuspid regurgitation or stenosis. And finally we have the pulmonic valve, normal, no pulmonic stenosis or regurgitation. Then you have the findings of the aorta. The ascending aorta diameter is 3.4 centimeters, which is normal. Then you can write about the pericardium. In this normal report, there is no pericardial effusion. This is the last section of the findings. It is additional findings. No intracardiac masses or thrombi identified. No patent foramen ovale or atrial septal defect noted on bubble study. Bubble study is a type of contrast study in which microbubbles are used. Atrial septal defect or a patent foramen ovale are more easily detected with bubble study. You can end the report by writing the conclusion. Normal echocardiogram with no evidence of structural or functional abnormalities. No further cardiac imaging required at this time. Patient should continue regular follow-ups with the referring physician. Here we have the first cardiac pathology, right atrial enlargement. The clinical indication is dyspnea. These are the findings of left ventricular function and dimensions. LV ejection fraction 58%, which is in normal range. LV internal diameter at diastole is 4.9 centimeters, which is also within normal range. LV internal diameter at diastole 4.9 centimeters. LV wall thickness is 0.8 centimeters. Global LV systolic function is normal. No regional wall motion abnormalities noted. So the left heart function and dimensions are normal. The left atrial diameter is 3.8 centimeters, which is also normal. These are the findings of the right ventricular and right atrial size and function. The right ventricle size is normal. The right ventricular function is also normal, but the right atrial size is severely enlarged. The right atrium demonstrates a marked increase in its anteroposterior dimension, suggesting significant chamber dilatation. Here are the findings of the valves. The mitral, aortic, and pulmonic valves are normal, but the tricuspid valve shows moderate tricuspid regurgitation. There is no tricuspid stenosis. These are the findings of the aorta. The ascending aorta diameter is 3.3 centimeters, which is normal. This is the pulmonary artery pressure. Estimated systolic pulmonary artery pressure measures 35 millimeters of mercury. The normal range is between 15 to 30 millimeters of mercury. This increased pressure is potentially related to the right atrial enlargement. There is no pericardial effusion. And here is the conclusion of this report. The echocardiogram reveals severe enlargement of the right atrium with associated moderate tricuspid regurgitation and elevated systolic pulmonary artery pressures. The findings are consistent with significant right atrial pathology and may suggest an underlying condition affecting the right side of the heart. Urgent cardiology consultation is recommended to determine the cause of the severe right atrial enlargement and to formulate a therapeutic plan. Further studies such as a cardiac MRI or right heart catheterization may be considered based on clinical evaluation. Here is a case of left atrial enlargement. Clinical indication is palpitations and suspected atrial abnormalities. Here are the findings of the left ventricular function and dimensions. Ejection fraction is 57%. Internal diameter at diastole is 5.1 centimeters. The LV wall thickness is 1 centimeter. Global LV systolic function is normal. No regional wall motion abnormalities noted. The left atrial diameter is 4.5 centimeters, which is more than normal. The left atrium is noted to be enlarged, suggesting left atrial dilatation. The right ventricular size is normal. The right ventricular function is normal. and the right atrial size is also normal. The mitral valve shows mild mitral regurgitation with normal morphology, no mitral stenosis. The aortic valve is normal. The tricuspid and the pulmonic valves are also normal. The ascending aorta diameter is 3.2 centimeters, which is normal. The estimated systolic pulmonary artery pressure is 24 millimeters of mercury, so this is normal. There is no pericardial effusion. Here is the conclusion. The echocardiogram reveals an enlargement of the left atrium and associated mild mitral regurgitation. The findings suggest potential left atrial pathology, which could be due to a variety of underlying conditions, including increased left ventricular filling pressures or chronic mitral valve disease. Cardiology consultation is advised to further assess the cause of the left atrial enlargement and its potential implications. Depending on clinical findings and symptoms, further investigations or interventions might be warranted. This is a case of mild mitral regurgitation. The indication is evaluation of a heart murmur. The ejection fraction is 60%. Internal diameter at diastole is 5 centimeters. LV wall thickness is 0.9 centimeter. Global LV systolic function is normal. No regional wall motion abnormalities noted. The left atrial diameter is 3.8 centimeters, which is normal. The right ventricle and atrial size is normal, and the right ventricular function is normal as well. Here are the findings in the valves. Mild mitral regurgitation observed in the mitral valve with color Doppler. The valve morphology appears normal. No evidence of prolapse or mitral stenosis. The other valves are normal. The ascending aorta diameter is 3.2 centimeters. The estimated systolic pulmonary artery pressure is 23 millimeters of mercury, which is normal. There is no pericardial effusion. This is the conclusion. The echocardiogram reveals mild mitral regurgitation without evidence of underlying valve deformity or dysfunction. The rest of the cardiac structures appear normal. Monitor the mitral regurgitation periodically to ensure it doesn't progress or lead to other complications. The patient should report any new or worsening symptoms, and follow-ups may be scheduled as clinically indicated. Now I will include only the findings which are abnormal. The normal findings are excluded because of repetition. So from now on, you will only see the abnormal findings in each case. This report is of moderate mitral regurgitation. Clinical indication is shortness of breath and evaluation of a heart murmur. The left atrial diameter is 4.2 centimeters. It is above normal. It is suggesting left atrial enlargement. These are the findings in the valves. Mitral valve, moderate mitral regurgitation observed with color Doppler. The valve morphology shows mild thickening, no evidence of prolapse, no mitral stenosis observed. The rest of the valves are normal. Here is the conclusion. The echocardiogram reveals moderate mitral regurgitation with mild valve thickening. There is associated left atrial enlargement, which could be a result of the increased volume from the mitral regurgitation. The rest of the cardiac structures appear normal. Further evaluation by a cardiologist is recommended to determine the etiology of the mitral regurgitation and potential therapeutic interventions. Depending on clinical findings and symptoms, additional tests, such as a transesophageal echocardiogram, might be warranted. Regular follow-up echocardiography should be considered to monitor the progression or resolution of the mitral regurgitation. Here is a report for severe mitral regurgitation. Clinical indication is progressive dyspnea, fatigue, and evaluation of a heart murmur. These are the findings. Left atrial diameter is 4.7 centimeters, indicating significant left atrial enlargement. Here are the findings of the valves. In the mitral valve, severe mitral regurgitation is observed with color Doppler. The valve morphology displays leaflet prolapse with possible chordal elongation or rupture. No significant mitral stenosis observed. The aortic valve is normal. The tricuspid valve shows trace tricuspid regurgitation and no tricuspid stenosis. The pulmonic valve is normal. Here is the conclusion. The echocardiogram demonstrates severe mitral regurgitation with associated significant left atrial enlargement. The etiology appears to be related to mitral valve leaflet prolapse and possible chordal pathology. The left ventricular dimensions and function are preserved at this time. Urgent cardiology consultation is advised to assess the need for possible surgical intervention or mitral valve repair or replacement. Additionally, the patient should be educated on recognizing symptoms of congestive heart failure. Serial echocardiograms are recommended to monitor the severity and potential complications of the mitral regurgitation. This is a report for mild mitral stenosis. Clinical indication is evaluation of diastolic murmur and possible valvular disease. These are the findings in the valves. Mitral valve, mild mitral stenosis observed. The valve area was estimated at 1.8 centimeters square. So this area is below the normal value. There is evidence of mild leaflet thickening and reduced leaflet mobility. No significant mitral regurgitation observed. The aortic valve is normal. This is the conclusion. The echocardiogram reveals mild mitral stenosis with evidence of leaflet thickening and reduced mobility. There is no associated mitral regurgitation of significance. The left atrial size is within normal limits, and there is no evidence of increased pulmonary pressures. The patient should have regular cardiology follow-ups to monitor the progression of the mitral stenosis. Depending on clinical symptoms and progression of the stenosis, further interventions or surgical considerations may be needed in the future. This report is of moderate mitral stenosis. Clinical indication is palpitations, exertional dyspnea, and evaluation of diastolic murmur. The left atrial diameter is 4.4 centimeters, indicating mild left atrial enlargement, which is associated with the mitral stenosis. These are the findings of the valves. Mitral valve, moderate mitral stenosis observed. The valve area was estimated at 1.3 centimeters squared, which is less than the normal range. There is notable leaflet thickening, calcification, and commissural fusion. Trace to mild mitral regurgitation observed. The aortic valve is normal. Mild tricuspid regurgitation is observed. The pulmonic valve is normal. Here is the conclusion. The echocardiogram reveals moderate mitral stenosis with associated leaflet thickening, calcification, and commissural fusion. There is also evidence of mild left atrial enlargement, likely secondary to the stenosis. The left ventricular function remains preserved. Regular cardiology follow-ups are crucial to monitor the progression of mitral stenosis. Depending on clinical symptoms and potential progression of the stenosis, further diagnostic studies like transesophageal echocardiography or interventions like balloon valvuloplasty or valve replacement may be considered in the future. The patient should be educated on the importance of prophylaxis for endocarditis and should report any new or worsening symptoms. This is a case of severe mitral stenosis. Clinical indications are recent syncopal episode, exertional dyspnea, and known valvular heart disease. The left atrial diameter is enlarged. It is 4.8 centimeters, indicating significant left atrial enlargement. These are the findings of the valves. In the mitral valve, severe mitral stenosis observed. The valve area was estimated at 0.9 centimeters squared, which is much less than the normal range. There is significant leaflet thickening, extensive calcification, and commissural fusion. No notable mitral regurgitation. The aortic and pulmonic valves are normal, but the tricuspid valve has mild tricuspid regurgitation. Estimated systolic pulmonary artery pressure is 35 millimeters of mercury, which is increased, indicating mild pulmonary hypertension. So in severe mitral stenosis, pulmonary hypertension can also occur. Here is the conclusion. The echocardiogram demonstrates severe mitral stenosis with marked leaflet thickening, extensive calcification, and commissural fusion. Significant left atrial enlargement and mild pulmonary hypertension are present, likely secondary to the mitral stenosis. Left ventricular function remains preserved. Urgent cardiology consultation is advised. The patient may benefit from interventions like balloon valvuloplasty or mitral valve replacement. Given the severity of the stenosis, the patient should also be counseled regarding the need for prophylaxis for endocarditis and should be closely monitored for symptoms of heart failure. Here is a case of mild aortic stenosis. Clinical indication is evaluation of systolic murmur and occasional chest discomfort. These are the findings of the valves. Aortic valve, mild aortic stenosis observed, peak velocity of 3 meters per second, which is more than the normal value. Normally it should be less than 2 meters per second. Estimated aortic valve area is 1.8 centimeters square. The normal value should be more than 2 centimeters squared. Mild leaflet thickening with preserved mobility. The mitral valve has normal morphology and function with trace regurgitation. The tricuspid and pulmonic valves were normal. Here is the conclusion. The echocardiogram reveals mild aortic stenosis with mild leaflet thickening but preserved leaflet mobility, no significant left ventricular hypertrophy or dilatation observed. The left ventricular systolic function is within normal limits. The other cardiac chambers and valves appear normal. Periodic echocardiographic follow-up is recommended to monitor the progression of the aortic stenosis. The patient should be educated about the symptoms of aortic stenosis and advised to report any new or worsening symptoms. This is a report for moderate aortic stenosis. The clinical indication is evaluation of worsening exertional dyspnea and systolic murmur. These are the findings of left ventricular function and dimensions. The ejection fraction is 60%, which is normal. The left ventricle internal diameter at diastole is 4.9 centimeters, which is also normal. The left ventricle wall thickness is 1.2 centimeters, which is slightly thickened, suggestive of compensatory hypertrophy. Global LV systolic function is normal. No regional wall abnormalities noted. The left atrial diameter is slightly enlarged. It is 4.1 centimeters, indicative of mild enlargement. The aortic valve shows moderate aortic stenosis, peak velocity of 3.5 meters per second, which is higher than normal. Estimated aortic valve area is 1.2 centimeters squared. Notable leaflet thickening and calcification with reduced leaflet mobility. The mitral valve has normal morphology and function with trace regurgitation. The tricuspid valve has trace regurgitation as well. The pulmonic valve is normal. Here is the conclusion. The echocardiogram demonstrates moderate aortic stenosis characterized by notable leaflet thickening, calcification, and reduced mobility. The left ventricle displays compensatory hypertrophy, likely secondary to the increased afterload from the aortic stenosis. The left atrial size is mildly enlarged. The left ventricular systolic function remains within normal limits. Close clinical and echocardiographic follow-up is advised. The patient should be educated about the signs and symptoms of worsening aortic stenosis. Consideration of potential future interventions, such as aortic valve replacement, may be warranted depending on the clinical progression and symptoms. This is a report for severe aortic stenosis. The clinical indications are syncope, worsening exertional dyspnea, and systolic murmur on examination. The ejection fraction is 55%. The LV internal diameter at diastole is 5.1 centimeters. The LV wall thickness is 1.3 centimeters, indicative of significant compensatory hypertrophy. Global LV systolic function is mildly reduced. No regional wall motion abnormalities observed. The left atrial diameter is 4.5 centimeters, which is indicative of enlargement. The aortic valve shows severe aortic stenosis. Peak velocity is 4.5 meters per second. Estimated aortic valve area is 0.8 centimeters square. Significant leaflet thickening, calcification, and reduced leaflet mobility. Mitral valve, mild mitral regurgitation. The pulmonic valve is normal. Here is the conclusion. The echocardiogram reveals severe aortic stenosis characterized by marked leaflet thickening, calcification, and severely restricted mobility. There is significant left ventricular hypertrophy, likely secondary to the chronic increased afterload. Left ventricular systolic function is mildly reduced. The left atrium is enlarged, and there is mild mitral regurgitation. Urgent cardiology consultation is recommended for consideration of aortic valve intervention, either surgical aortic valve replacement or transcatheter aortic valve replacement based on the patient's suitability and other clinical parameters. The patient should be informed about the urgency and potential risks associated with untreated severe aortic stenosis. This report is of mild aortic calcification. Clinical indication is routine cardiac evaluation and systolic murmur on examination. These are the findings. The aortic valve has mild calcifications on the aortic valve leaflets. No significant stenosis or regurgitation observed. Peak velocity of 2 meters per second. Estimated aortic valve area remains within normal limits. The mitral valve has trace regurgitation. The tricuspid and pulmonic valves are normal. Here is the conclusion. The echocardiogram reveals mild calcification of the aortic valve leaflets without significant stenosis or regurgitation. Left ventricular systolic function and chamber sizes are within normal limits. There is a trace of mitral regurgitation. Periodic echocardiographic follow-up is suggested to monitor the progression of aortic valve calcification. The patient should be educated about potential symptoms related to aortic valve disease and advised to report any new or worsening symptoms. This is a report of moderate aortic calcification. Clinical indication is routine cardiac evaluation and systolic murmur on examination. These are the findings in the valves. Aortic valve, moderate calcification observed on the aortic valve leaflets. There is no significant stenosis with a peak velocity of 2.5 meters per second. No aortic regurgitation is evident. The leaflet motion appears to be mildly restricted due to the calcification. The mitral valve has trace regurgitation. The tricuspid and pulmonic valves are normal. This is the conclusion. The echocardiogram demonstrates moderate calcification of the aortic valve leaflets, which mildly restricts leaflet motion but has not resulted in significant stenosis or regurgitation at this time. Left ventricular systolic function and chamber sizes are within normal limits. Trace mitral regurgitation is observed. Regular echocardiographic surveillance is recommended to monitor the progression of aortic valve calcification and potential development of stenosis. The patient should be educated about the potential for progression of aortic valve disease and advised to promptly report any new or worsening symptoms. This is a case of severe aortic calcification. Clinical indication is evaluation for symptomatic shortness of breath and known systolic murmur. The ejection fraction is 58%. The LV internal diameter at diastole is 5 centimeters. The left ventricle wall thickness is 1.2 centimeters, suggesting compensatory hypertrophy. Global LV systolic function is preserved. No regional wall motion abnormalities observed. The left atrial diameter is 4.2 centimeters, indicative of enlargement. In the aortic valve, severe calcification of the aortic valve leaflets is noted. The leaflet motion is significantly restricted due to the calcification. Peak velocity of 3.8 meters per second with a mean gradient suggestive of moderate stenosis. No significant aortic regurgitation observed. The mitral valve has trace regurgitation. The tricuspid and pulmonic valves are normal. This is the conclusion. This echocardiogram demonstrates severe calcification of the aortic valve leaflets, leading to significant restriction of leaflet motion and moderate aortic stenosis. Compensatory left ventricular hypertrophy is present, likely secondary to the increased afterload from the stenosis. Left atrial size is mildly enlarged. Cardiology consultation is urgently recommended for evaluation and management options, including potential aortic valve intervention. The patient should be educated about the seriousness of severe aortic valve calcification and potential symptoms to monitor. This is a case of mild aortic regurgitation. Clinical indication is evaluation of cardiac murmur. These are the findings of the aortic valve. Normal valve leaflets. Mild aortic regurgitation is observed with a regurgitant jet width of approximately 20% of the left ventricular outflow tract diameter. In the mitral valve, normal morphology with trace regurgitation is seen. The tricuspid and pulmonic valves are normal. Here is the conclusion. The echocardiogram reveals mild aortic regurgitation without stenosis or significant valve deformity. Left ventricular function and chamber sizes are within normal limits. Periodic echocardiographic follow-up is advised to monitor the progression of aortic regurgitation. The patient should be made aware of potential symptoms related to aortic valve disease and be advised to seek medical attention if any new or worsening symptoms arise. This is a report for severe aortic regurgitation. Clinical indication is evaluation for exertional dyspnea and known cardiac murmur. These are the findings of left ventricular function and dimensions. Ejection fraction is 55%. LV internal diameter at diastole is 5.8 centimeters, suggestive of dilatation. LV wall thickness is 1.1 centimeters. Global LV systolic function is mildly reduced. No regional wall motion abnormalities noted. The left atrial diameter is 4.5 centimeters, which is indicative of enlargement. In the aortic valve, leaflet thickening is observed. Severe aortic regurgitation is present with a white regurgitant jet encompassing more than 65% of the left ventricular outflow tract diameter. The vena contracta width and pressure half-time measurements are also consistent with severe regurgitation. No significant stenosis noted. In the mitral valve, mild mitral regurgitation observed, likely secondary to annular dilatation from increased left ventricular size. The tricuspid valve shows trace regurgitation. Pulmonic valve is normal. This is the conclusion. This echocardiogram demonstrates severe aortic regurgitation associated with left ventricular dilatation and mild systolic dysfunction. There is also enlargement of the left atrium. Urgent cardiology consultation is recommended for discussion of potential surgical intervention. The patient should be educated on the severity of the aortic regurgitation and advised to monitor for worsening or new symptoms. This is a report for pulmonary regurgitation. Clinical indication is evaluation for palpitations and exertional dyspnea. The aortic, mitral, and tricuspid valves are normal. In the pulmonic valve, pulmonary regurgitation is observed with a regurgitant jet width of approximately 30% of the right ventricular outflow tract diameter. This is the conclusion. The echocardiogram demonstrates pulmonary regurgitation without evidence of significant pulmonary hypertension. Other cardiac chambers and valves appear normal. Regular echocardiographic follow-up is advised to monitor the progression of pulmonary regurgitation and potential development of right ventricular dysfunction. The patient should be educated on potential symptoms related to valve disease and be advised to seek medical attention if any new or worsening symptoms arise. This is an example report of mild pulmonary stenosis. Clinical indication is evaluation for cardiac murmur. The aortic, mitral, and tricuspid valves are normal. In the mitral valve, mild pulmonary stenosis is observed. Peak gradient across the pulmonic valve is measured at 35 millimeters of mercury. The valve leaflets show minimal thickening with no commissural fusion. Here is the conclusion. The echocardiogram reveals mild pulmonary stenosis without significant hemodynamic compromise. Other cardiac chambers and valves are within normal limits. Periodic echocardiographic follow-up is recommended to monitor the progression of pulmonary stenosis. The patient should be educated on the condition and advised to monitor any symptoms related to valve disease. This report is of moderate pulmonary stenosis. Clinical indication is evaluation for cardiac murmur and reduced exercise tolerance. The aortic, mitral, and tricuspid valves are normal. In the pulmonic valve, moderate pulmonary stenosis is identified. Peak gradient across the pulmonic valve is measured at 50 millimeters of mercury. There is evident leaflet thickening and mild doming in systole. Here is the conclusion. The echocardiogram demonstrates moderate pulmonary stenosis with a peak gradient of 50 millimeters of mercury. The leaflets of the pulmonic valve exhibit thickening and mild doming. Other cardiac structures appear normal. The patient should be referred to a cardiologist for further evaluation and potential management of pulmonary stenosis. Periodic echocardiographic surveillance is advised to monitor the progression of the stenosis and potential right ventricular impact. This is a case of severe pulmonary stenosis. Clinical indication is evaluation for cardiac murmur and marked exercise intolerance. The right ventricular size is mildly enlarged, right ventricular function is mildly reduced, and the right atrial size is normal. The aortic, mitral, and tricuspid valves are normal. In the pulmonic valve, severe pulmonary stenosis is noted. Peak gradient across the pulmonic valve is measured at 67 millimeters of mercury, which indicates severe stenosis. The valve leaflets are significantly thickened with reduced mobility and noticeable doming in systole. The estimated systolic pulmonary artery pressure is 40 millimeters of mercury. It is increased. This is the conclusion. The echocardiogram reveals severe pulmonary stenosis with a peak gradient of 67 millimeters of mercury, resulting in right ventricular enlargement and mild functional impairment. Other cardiac chambers and valves are within normal limits. Urgent referral to a cardiologist is advised for further evaluation and potential intervention. Periodic echocardiographic monitoring is crucial to assess the progression of stenosis and the right ventricular response. This is a report for mild tricuspid regurgitation. Clinical indication is evaluation for cardiac murmur and palpitations. The aortic, mitral, and pulmonic valves are normal. In the tricuspid valve, mild tricuspid regurgitation is observed. The regurgitant jet is central with a width of approximately 0.9 centimeters. Estimated systolic pulmonary artery pressure based on tricuspid regurgitant velocity is 25 millimeters of mercury. So the pulmonary artery pressure is within normal range. This is the conclusion for this case. The echocardiogram demonstrates mild tricuspid regurgitation without significant hemodynamic impact. Other cardiac structures appear normal. Periodic echocardiographic follow-up is recommended to monitor the tricuspid regurgitation and its potential progression. The patient should be advised to monitor for any symptoms related to valve disease. This is a report for severe tricuspid regurgitation. Clinical indication is evaluation for cardiac murmur, leg swelling, and exertional dyspnea. The right ventricular size is mildly enlarged, right ventricular function is mildly reduced, and the right atrial size is significantly enlarged. These findings are usually seen in severe tricuspid regurgitation. The aortic, mitral, and pulmonic valves are normal. In the tricuspid valve, severe tricuspid regurgitation is evident. The regurgitant jet is broad and eccentric, with vena contracta greater than 0.7 centimeters. There is significant leaflet tethering and malcoaptation. The annulus is dilated. Estimated systolic pulmonary artery pressure based on tricuspid regurgitant velocity is 40 millimeters of mercury. Here is the conclusion. The echocardiogram reveals severe tricuspid regurgitation with significant annular dilatation and leaflet tethering, leading to right atrial enlargement and mild right ventricular functional impairment. Other cardiac structures are within normal limits. Urgent referral to a cardiology specialist is advised for further evaluation and potential intervention. Medical management and considerations for tricuspid valve repair or replacement may be indicated based on clinical symptoms and findings. This is a case of tricuspid stenosis. Clinical indication is evaluation for right-sided symptoms and a diastolic murmur heard at the left lower sternal border. The right ventricular size and function are normal, but the right atrial size is moderately enlarged. The aortic, mitral, and pulmonic valves are normal. In the tricuspid valve, tricuspid stenosis is observed. Peak gradient across the tricuspid valve is 5 millimeters of mercury. This indicates mild stenosis. The valve leaflets appear thickened with reduced leaflet mobility. There is a mild decrease in tricuspid valve area. Here is the conclusion. The echocardiogram demonstrates tricuspid stenosis with thickened valve leaflets and reduced leaflet mobility. This is associated with moderate right atrial enlargement. Other cardiac structures are within normal limits. Regular follow-up with a cardiology specialist is recommended to monitor the progression of the tricuspid stenosis and associated right atrial enlargement. Management strategies may vary based on the progression of the disease and the presence of any symptoms. Now we move on to mild pericardial effusion. Clinical indication is evaluation for non-specific chest discomfort and recent viral illness. These are the findings of the pericardium. Mild pericardial effusion is observed circumferentially around the heart. There is no evidence of cardiac tamponade or hemodynamic compromise related to the effusion. The effusion appears anechoic, suggesting a transudative nature. This is the conclusion. The echocardiogram demonstrates a mild pericardial effusion without evidence of hemodynamic compromise. The remaining cardiac structures are within normal limits. Close monitoring and a potential follow-up echocardiogram in a few weeks are advised to evaluate for resolution or progression of the pericardial effusion. Consider further evaluation, including laboratory tests or pericardiocentesis. If there is clinical concern for an inflammatory or infectious etiology. Now we have a case of moderate pericardial effusion. Clinical indication is evaluation for dyspnea, chest pain, and tachycardia. These are the findings in the pericardium. Moderate pericardial effusion is observed circumferentially around the heart. The effusion is most pronounced posteriorly. There are no clear signs of cardiac tamponade at rest, but the effusion's presence warrants close monitoring. The effusion appears to be of mixed echogenicity. Here is the conclusion. The echocardiogram shows a moderate pericardial effusion surrounding the heart without clear signs of hemodynamic compromise. The rest of the cardiac structures appear within normal limits. Admission for close monitoring is advised. A follow-up echocardiogram within 24 to 48 hours is recommended to assess the effusion's progression. Consideration for diagnostic pericardiocentesis may be necessary depending on clinical evolution and if there are concerns for an inflammatory, infectious, or malignant etiology. This is a report for a large pericardial effusion. Clinical indications are evolution for progressive dyspnea, jugular venous distension, and pulsus paradoxus. The right ventricular size is normal. Right ventricular function is normal with slight diastolic collapse suggestive of impending tamponade physiology. And the atrial size is normal with intermittent systolic collapse. These are the findings in the pericardium. Large pericardial effusion is observed circumferentially around the heart. There is evidence of diastolic right ventricular collapse and intermittent systolic right atrial collapse, suggestive of impending tamponade physiology. The effusion's character varies with areas of mixed echogenicity. Here is the conclusion. The echocardiogram demonstrates a large pericardial effusion with signs suggestive of impending cardiac tamponade. Immediate medical attention is required. Immediate hospital admission for hemodynamic monitoring and consideration for urgent pericardiocentesis. Consultation with cardiology is imperative. Further evaluation and management should be tailored based on clinical presentation, hemodynamic stability, and the suspected underlying cause of the effusion. This is a case of cardiac tamponade. Clinical indications are evaluation for sudden onset dyspnea, chest pain, hypotension, elevated jugular venous pressure, and muffled heart sounds. The ejection fraction is 57%. Left ventricle internal diameter at diastole is 4.5 centimeters. The wall thickness of the left ventricle is 0.8 centimeters. Global LV systolic function is decreased. The right ventricle size is normal, but the right ventricular function is affected. Diastolic collapse is noted. The right atrial size shows intermittent systolic collapse. The aortic valve is normal, but in the mitral valve, early diastolic flow reversal observed in the pulmonary veins. The pulmonic valve is normal, and in the tricuspid valve, exaggerated respiratory variation in tricuspid inflow is observed. Large pericardial effusion is observed circumferentially around the heart. Diastolic collapse of the right ventricle along with intermittent systolic right atrial collapse is present. The findings are consistent with cardiac tamponade. The effusion displayed is anechoic. Additional findings include respiratory variation in mitral and tricuspid inflow velocities, dilated inferior vena cava with reduced collapsibility. This is the conclusion. The echocardiogram reveals a large pericardial effusion with signs consistent with cardiac tamponade, including diastolic collapse of the right ventricle, systolic collapse of the right atrium, and hemodynamic changes associated with tamponade. Immediate therapeutic intervention is required. Urgent pericardiocentesis should be considered to relieve the tamponade and stabilize the patient. A cardiology consultation is imperative for further management and evaluation of the effusion's etiology. This is a report for constrictive pericarditis. Clinical indications are evaluation for chronic dyspnea, fatigue, leg swelling, and elevated jugular venous pressure with a Kussmaul's sign. The right ventricular size is normal, but in the right ventricular function, it is normal with septal bounds noted. The right atrial size is enlarged. The aortic valve is normal. In the mitral valve, respiratory variation in mitral inflow velocity is observed. The pulmonic valve is normal. In the tricuspid valve, marked respiratory variation in tricuspid inflow is noted. These are the findings of the pericardium. Thickened pericardium is observed, especially over the anterior surface of the heart. No significant pericardial effusion present. Here are the Doppler findings. Exaggerated respiratory variation in mitral and tricuspid inflow velocities. Early diastolic flow reversal in hepatic veins. Dilated inferior vena cava with reduced collapsibility. These are the additional findings. Septal bounds observed consistent with ventricular interdependence. Annulus reversus. The lateral mitral annular E velocity is less than the septal E velocity on tissue Doppler imaging. Here is the conclusion. The echocardiographic findings, including thickened pericardium, septal bounds, exaggerated respiratory variation in mitral and tricuspid inflow velocities, early diastolic flow reversal in hepatic veins, and annulus reversus, are consistent with constrictive pericarditis. Further evaluation with cardiac MRI or CT may be beneficial to assess the full extent of pericardial thickening. Surgical consultation for potential pericardiectomy should be considered based on clinical presentation and additional findings. This is a report for ventricular interdependence. Clinical indications are evaluation for dyspnea, peripheral edema, and ascites with history suggestive of constrictive physiology. The right ventricular size is normal. The right ventricular function is normal with notable septal bounce. The right atrial size is slightly enlarged. The aortic valve is normal. In the mitral valve, respiratory variation in mitral inflow velocity is seen. Pulmonic valve is normal. In tricuspid valve, exaggerated respiratory variation in tricuspid inflow. These are the findings in the pericardium. Evidence of significant pericardial effusion with a thickened pericardium, especially anteriorly. These are the Doppler findings. Marked respiratory variation in both mitral and tricuspid inflow velocities. Doppler tissue imaging shows significant variation in E velocities with respiration. These are additional findings. Ventricular interdependence is evident, most notably by the septal bounce observed. This is indicative of mechanical effects of one ventricle on the other, often seen in constrictive pericarditis. This is the conclusion. The echocardiographic findings show evidence of ventricular interdependence demonstrated by a septal bounce, respiratory variations in mitral and tricuspid inflow velocities, and findings consistent with a thickened pericardium. Significant pericardial effusion is also present. These findings are suggestive of a constrictive physiology, likely due to constrictive pericarditis. Further diagnostic imaging, potentially with cardiac MRI or CT, can help confirm the diagnosis and assess the full extent of pericardial involvement. A cardiology consultation is advised to discuss potential management options, including possible surgical intervention. Here is a report of sigmoid-shaped septum. Clinical indication is evaluation for dyspnea on exertion and a history of hypertrophic cardiomyopathy in the family. These are the findings in the valves. Aortic valve is normal. In the mitral valve, mild systolic anterior motion of the anterior mitral valve leaflet is observed. The pulmonic and tricuspid valves are normal. These are the findings in the interventricular septum. A sigmoid-shaped septum is noted, with hypertrophy predominantly in the basal and mid segments of the anterior septum. This leads to a potential narrowing of the left ventricular outflow tract, especially during systole. Here are the Doppler findings. Mild left ventricular outflow tract gradient detected, suggestive of dynamic LVOT obstruction. Rest of the Doppler measurements are within normal limits. Here are additional findings. Systolic anterior motion of the mitral valve observed, associated with the sigmoidal shape of the septum. And this is the conclusion. Echocardiographic findings reveal a sigmoid-shaped septum with evidence of septal hypertrophy predominantly in the basal and mid segments. This morphological change, along with the observed SAM of the mitral valve, is suggestive of potential dynamic LVOT obstruction. The overall picture is consistent with a variant of hypertrophic cardiomyopathy. Clinical correlation is essential, and the patient may benefit from further evaluation, including a stress echocardiogram, to assess the significance of the LVOT gradient under exertional conditions. Management decisions should be made in consultation with a cardiologist familiar with hypertrophic cardiomyopathy and its variants. Now we move on to restrictive cardiomyopathy. Clinical indication is evaluation for fatigue, dyspnea, and lower extremity edema with a clinical suspicion of restrictive cardiomyopathy. The ejection fraction is 55%. Internal diameter at diastole is 4.2 centimeters. LV wall thickness is 1 centimeter. Global LV systolic function is preserved. Diastolic function shows restrictive filling pattern. The left atrial diameter is 4.5 centimeters. It is enlarged. The right ventricular size and function are normal. The right atrial size is enlarged. The aortic valve is normal. The mitral valve is normal but with a rapid early filling wave, E wave, and a diminished atrial filling wave, that is A wave on Doppler. Pulmonic valve is normal, and in the tricuspid valve, similar filling pattern to mitral valve with elevated E wave velocity is seen. Mitral inflow pattern reveals elevated E wave velocity and reduced A wave velocity, consistent with a restrictive filling pattern. Pulmonary vein flow demonstrates a blunted S wave and an elevated D wave. These are additional findings. Biatrial enlargement observed. Tissue Doppler imaging shows reduced myocardial velocities suggestive of myocardial stiffness. No significant pericardial effusion. This is the conclusion. Echocardiographic findings are consistent with restrictive cardiomyopathy. The study reveals biatrial enlargement, preserved systolic function with restrictive diastolic filling pattern, and evidence of increased myocardial stiffness. Further diagnostic evaluation, including cardiac MRI and possibly endomyocardial biopsy, may be considered to identify the specific etiology of the restrictive cardiomyopathy and guide therapeutic strategies. A cardiology consultation is recommended to discuss management and potential therapeutic interventions. Here is a case of hypertrophic cardiomyopathy. Clinical indication is evaluation for exertional chest pain and palpitations with a family history of hypertrophic cardiomyopathy. Ejection fraction is 65%. Internal diameter at diastole is 3.5 centimeters. LV wall thickness is asymmetric hypertrophy with anterior septal wall measuring 1.9 centimeter in thickness. Global LV systolic function is preserved. Noted is an apical aneurysm measuring approximately 1.2 centimeters in diameter. The left atrial diameter is 4.4 centimeters, enlarged due to elevated LV filling pressures. The aortic, pulmonic, and tricuspid valves are normal, but in the mitral valve, there is evidence of mild systolic anterior motion of the anterior mitral valve leaflet. These are the Doppler findings: mild gradient across the LVOT. Mitral inflow pattern reveals diastolic dysfunction consistent with impaired relaxation. These are additional findings. An apical aneurysm is visualized. Papillary muscles appear hypertrophied. Small LV cavity size due to wall hypertrophy, and no significant pericardial effusion. This is the conclusion. The echocardiographic findings are consistent with hypertrophic cardiomyopathy with a notable apical aneurysm. There is evidence of asymmetric septal hypertrophy and mild dynamic LVOT obstruction secondary to SAM. The presence of an apical aneurysm with potential for thrombus formation in HCM is a high-risk feature and warrants urgent clinical attention. Immediate cardiology consultation is advised given the potential risk of thrombus formation within the apical aneurysm. Anticoagulation therapy should be considered. Genetic testing and counseling may be beneficial given the familial nature of the condition. A comprehensive evaluation, including a cardiac MRI, may be useful in further delineating the anatomy and the extent of disease, as well as guiding management. This is a report of non-compaction cardiomyopathy. Clinical indications are evaluation for progressive fatigue, palpitations, and family history suggestive of non-compaction cardiomyopathy. The ejection fraction is 40%. It is reduced. LV internal diameter at diastole is 4.8 centimeters. Pronounced trabeculations and deep intertrabecular recesses observed, particularly in the apical and mid-ventricular segments of the lateral wall. The left atrial diameter is 4.6 centimeters. It is enlarged. The aortic, pulmonic, and tricuspid valves are normal, but in the mitral valve, mild regurgitation is noted. Mitral inflow pattern suggests diastolic dysfunction consistent with impaired relaxation. These are additional findings. The ratio of non-compacted to compacted myocardium is greater than 2 to 1 in the involved segments, which is suggestive of non-compaction cardiomyopathy. Color Doppler reveals blood flow within the deep intertrabecular recesses. No evidence of intracardiac thrombi. No evidence of pericardial effusion. Here is the conclusion. The echocardiographic findings are consistent with left ventricular non-compaction cardiomyopathy. Characteristic findings include pronounced trabeculations, deep intertrabecular recesses in the apical and mid-ventricular segments, and a non-compacted to compacted myocardium ratio greater than 2 to 1 in the involved segments. Clinical management should be tailored based on the patient's symptoms and risk of complications like heart failure, arrhythmias, and thromboembolic events. A cardiology consultation specializing in cardiomyopathies is recommended for further evaluation and management. Genetic testing and counseling may be considered given the potential familial nature of the condition. This report is of dilated cardiomyopathy. Clinical indications are evaluation for progressive shortness of breath, lower extremity edema, and a known family history of dilated cardiomyopathy. The ejection fraction is 25%, which is significantly reduced. The LV internal diameter at the stole is 6.2 centimeters. It is dilated. Global hypokinesia observed with diffusely reduced wall motion. The left atrial diameter is 5 centimeters. It is significantly enlarged. The right ventricular size is moderately enlarged. Right ventricular function is reduced, and right atrial size is moderately enlarged as well. Aortic valve shows mild regurgitation. Mitral valve shows moderate regurgitation. Pulmonic valve shows mild regurgitation, and the tricuspid valve shows moderate regurgitation. These are the Doppler findings. Mitral inflow pattern consistent with restrictive filling. Tricuspid regurgitant jet used to estimate right ventricular systolic pressure suggests elevated pulmonary artery pressure. These are additional findings. No intracardiac thrombi observed. Mild pericardial effusion. This is the conclusion. The echocardiographic findings are consistent with dilated cardiomyopathy. There is significant dilation and reduced function of the left ventricle with associated valvular regurgitations and elevated pulmonary pressures. Given the clinical and echocardiographic findings, the patient should be promptly evaluated for advanced heart failure therapies and medications. Consideration should be given for device therapy, such as a defibrillator or cardiac resynchronization therapy, based on current guidelines and the patient's clinical status. A cardiology consultation specializing in heart failure is recommended. Genetic testing and counseling may be beneficial, especially considering the family history. This is a case of pulmonary hypertension. Clinical indication is evaluation of progressive shortness of breath and exertional dyspnea. The right ventricular size is moderately enlarged. RV function is reduced. Right atrial size is moderately enlarged, and RV free wall thickness is increased. Aortic valve is normal. The mitral valve shows mild regurgitation. Pulmonic valve shows mild regurgitation, and the tricuspid valve shows moderate regurgitation. Tricuspid regurgitant jet velocity is 3.6 meters per second. Pulmonary artery systolic pressure estimated using tricuspid regurgitant jet and RA pressure is 50 millimeters of mercury, which is elevated. These are additional findings. Flattening D sign of the interventricular septum observed, suggestive of RV pressure overload. Inferior vena cava diameter is 2.5 centimeters with reduced collapsibility, suggesting elevated RA pressure. No significant pericardial effusion. Here is the conclusion. Echocardiographic findings are consistent with pulmonary hypertension. There is evidence of right ventricular and atrial enlargement, increased RV free wall thickness, and elevated estimated pulmonary artery systolic pressure. The patient should be referred to a pulmonary hypertension specialist for further evaluation, which might include right heart catheterization to confirm the diagnosis and determine the specific cause and severity of pulmonary hypertension, Treatment should be initiated based on the specific etiology of the pulmonary hypertension and current guidelines. This is a report for transposition of the great arteries. Clinical indication is evaluation of cyanosis and differential clubbing in a neonate with suspicion of a congenital heart defect. These are the findings of the great arteries. The aorta rises from the right ventricle and the pulmonary artery rises from the left ventricle, consistent with transposition of the great arteries. Both the left and right ventricles demonstrate normal systolic function, no significant ventricular dilation or hypertrophy. These are the findings of the atrial and ventricular septum. A large atrial septal defect is noted, which may be acting as a mixing lesion. The ventricular septum appears intact, with no ventricular septal defect noted. Aortic and pulmonary valves appear normal with no stenosis or regurgitation. Mitral and tricuspid valves show normal morphology and function. Patent ductus arteriosus is present, allowing for some mixing of oxygenated and deoxygenated blood. No coarctation of the aorta or other associated anomalies. Here is the conclusion. The echocardiographic findings are consistent with transposition of the great arteries with a large atrial septal defect and patent ductus arteriosus acting as mixing lesions. Urgent pediatric cardiology consultation is recommended. The patient may require a balloon atrial septostomy, a Rashkind procedure, to improve mixing while awaiting definitive surgical correction, such as the arterial switch operation. This is a case of truncus arteriosus. Clinical indication is evaluation of a murmur and cyanosis in a neonate with suspicion of a congenital heart defect. A single arterial trunk arising from the heart is observed, supplying both the systemic, pulmonary and coronary circulations consistent with truncus arteriosus. Both the left and right ventricles demonstrate normal systolic function. The right ventricle appears slightly dilated. These are the findings of atrial and ventricular septum. A large ventricular septal defect is noted beneath the truncal valve, effectively creating a single ventricular chamber. These are the findings in the valves. The truncal valve is tricuspid in morphology with moderate regurgitation. Mitral and tricuspid valves show normal morphology and function. These findings are related to pulmonary circulation. Pulmonary arteries branch off from the common arterial trunk. There is increased flow into the pulmonary circulation, suggestive of increased pulmonary blood flow, that is, pulmonary overcirculation. Here is the conclusion. The echocardiographic findings are consistent with truncus arteriosus with an associated large ventricular septal defect and truncal valve regurgitation. Urgent pediatric cardiology consultation is recommended. Surgical intervention is usually indicated within the first few weeks to months of life to separate the pulmonary and systemic circulations and close the VSD. This is a case of patent ductus arteriosus. Clinical indication is evaluation of a continuous murmur in a neonate with suspicion of congenital heart disease. These are the findings related to aortic arch and pulmonary arteries. A patent ductus arteriosus is visualized connecting the main pulmonary artery to the descending aorta. There is left to right shunting across the PDA confirmed by color Doppler. Left ventricular systolic function is normal. The LV appears mildly dilated, suggesting increased preload from the PDA. Both atrial and ventricular septa appear intact, with no evidence of atrial or ventricular septal defects. Aortic, mitral, pulmonic, and tricuspid valves appear normal, with no evidence of stenosis or regurgitation. These are Doppler measurements. Continuous wave Doppler across the PDA demonstrates a high velocity flow with a washing machine characteristic sound. There is evidence of increased pulmonary blood flow consistent with left to right shunting at the level of the PDA. No associated anomalies like coarctation of the aorta are seen. Here is the conclusion. The echocardiographic findings are consistent with a patent ductus arteriosus with left to right shunting. The left ventricle is mildly dilated due to the increased preload from the PDA. Monitoring of the PDA is recommended, and if it does not close spontaneously, medical or surgical intervention may be needed. A pediatric cardiology consultation is advisable for further management. This is a report for tetralogy of Fallot. Clinical indications are evaluation of cyanosis and murmur in an infant with suspicion of a congenital heart defect. A large, malaligned ventricular septal defect is noted in the membranous and outlet portions of the septum. These are the findings related to right ventricular outflow. There is significant obstruction to the RV outflow tract, consistent with pulmonary stenosis. The pulmonary valve appears thickened with decreased leaflet mobility. The main pulmonary artery appears hypoplastic. The right ventricular free wall is markedly thickened, indicating significant right ventricular hypertrophy. The aorta is seen to override the ventricular septum with a biventricular connection, receiving blood from both the right and left ventricles. This is the conclusion. The echocardiographic findings are consistent with tetralogy of Fallot, comprising of the four classic features: ventricular septal defect, pulmonary stenosis, right ventricular hypertrophy, and an overriding aorta. Surgical repair is typically recommended in early life, usually within the first year. A pediatric cardiology consultation is necessary for further management and planning for possible surgical intervention. Thank you so much for watching. Please subscribe and stay tuned for more imaging videos.